Dr. NEENA R. Evaluation of functional and cosmetic outcome after surgical correction of monocular elevation defect.
Very good afternoon to one and all. And my aim was to analyze functional and cosmetic outcome after surgical correction of monocular elevation defect. As you can see here, monocular elevation defect is a challenging strabismus which is characterized by limitation of elevation in all cases, both in adduction and abduction, with normal adductions in other cases. It is often complicated by presence of abnormal head posture, ptosis, which can be true or pseudo, presence of Marcus-Gunn jaw-winking phenomenon, horizontal deviations, DVDs, and amblyopia. So this was classified into three types based on the presence of Bell's phenomenon, the behavior of the FDT, and the other elevation saccades. So type 1 is a restrictive type with tight inferior rectus and a positive FDT. Type 2 is a superior rectus paralysis kind of condition with a negative FDT. And type 3 is a typical supranuclear MED with a preserved Bell's phenomenon and a negative FDT. So the aim in this study, what we did was we did a retrospective analysis of all patients with monocular elevation defect who underwent surgical correction at our center from 2022 to 23, and we compared the various surgical techniques with a minimum follow-up of 6 months. So these were the parameters we assessed. Apart from the demographic factors, we looked into the amount of hypertropia, the severity of elevation limitation, and the presence of other characteristics like AHP, ptosis, Marcus-Gunn jaw-winking phenomenon, Bell's phenomenon, horizontal deviations, DVDs, refractive errors, BSV, amblyopia, and we did an FTT for all patients. So coming to the surgical planning, the amount of hypertropia, status of the forced duction test, presence of abnormal head posture, true ptosis, Marcus-Gunn jaw-winking phenomenon, horizontal deviations were key determinants in our surgical planning. So if we had a type 1 MED, we mostly advocated a weakening of the inferior rectus with or without superior rectus strengthening. If we had a type 2, we mainly advocated a transposition surgery to the superior rectus, and at type 3, a combination. So when we had a larger hypertropia, toe muscle surgery was planned. Ptosis, true ptosis, and Marcus-Gunn jaw-winking required additional ptosis surgery, and this was conveyed to the patient. And horizontal strabismus surgery patients were told that they would require additional surgery in the contralateral eye, and a surgical success was defined as a vertical deviation less than or equal to 4 prisms of hypertropia with reduction in abnormal head posture with or without restoration of the binocular single vision. So coming to results, we had total 9 patients, slightly more females. Most of them were in the younger age group. 13.55 was the mean age. All were congenital MEDs. Abnormal head position was seen in about 55.5% patients. Ptosis was the most common complaint. Marcus-Gunn jaw-winking was seen in about 44.4% patients. The mean pre-op hypertropia was 26.7 for distance and 16.4 for near. And DVD was seen in 2 and horizontal deviation in 1 patients. Refractive error in 44.4% patients and amblyopia in 66.67 patients. We had mostly type 2 MEDs. So if you look at the Bell's phenomenon, it was absent in 55% patients and FTT was negative in those. So if you look at the type of squint surgery, most of them underwent a transposition surgery. And if you look at the improvement in the elevation, you can see it improved very well from minus 2.89 pre-op to minus 0.56 post-op, and the hypertropia for distance fell from 26.78 of a mean deviation to 3.3 post-op, and hypertropia for near also improved from 16.44 to 0.89 post-op, and all these were statistically significant with significant p-value. So in our study, about 88.8% of the ptosis improved, although 4 needed additional ptosis correction. 80% of the AHBs improved, 75% of the chin elevation limitation improved, and 71.4% with preoperative suppression for distance regained fusion after surgery, and 85.7% regained near stereopsis better or equal to 100 arc seconds. So this gives you the improvement in the stereopsis from 92.5 to 52.5 post-op with a significant p-value. So coming to a surgical success, you can see some of these. This child had a type 1 MED with a very small hypertropia and a positive FDT. We only did an inferior rectus recession and she was good. Type 1 MED with positive FDT and ptosis. This gentleman had to undergo an inferior rectus recession in the same eye with a superior rectus resection and finally a ptosis correction, and he's well corrected. This lady had Marcus Gunn ptosis and she required, along with vertical muscle surgery, she required a ptosis correction also. Negative FTT type 2, we did a NAPS procedure. You can see here the wonderful improvement in the hypertropia post-surgery with good alignment and good improvement in the ptosis. Type 2 MED, we can also do this procedure which is known as a modified Nishida, in which no tenotomy, no disinsertion of the muscles, and we just transpose 1/3 of the muscles in the superolateral and supromedial compartments of the sclera with a non-absorbable sutures, and you get good alignment. Type 2 MED with Marcus Gunn ptosis is more difficult to manage. This child had an augmented NAPS but will require more surgery for ptosis. So again, horizontal surgeries required R&R in the other eye, that is recess resect in the normal eye for the horizontal deviation and a vertical rectus surgery, or a NAPS procedure. This child had a NAPS in the concerned eye. So what did we find different in our study? In our series, we found that small hypertropias less than 15 prisms in type 1 MEDs did well with inferior rectus weakening alone. And we found that ipsilateral superior rectus strengthening procedure was more acceptable to correct the residual hypertropia. And now in type 2 MEDs with negative FDTs, NAPS procedure and modified Nishidas were equally effective in improving the hypertropia. And true ptosis and Marcus Gunn jaw winking phenomenon needed additional ptosis correction. Surgical intervention and occlusion therapy improved the binocularity and amblyopia in our surgery, and good cosmesis with good improvement in AHP was seen in all patients. So study is relevant because this is one of the few studies to analyze and compare the surgical options in MED, especially associated with these complications like ptosis and Marcus Gunn. In the end, I'd like to sum up and say that identifying the type of MED, appropriate surgical planning, and staged surgery will give you satisfactory cosmetic and functional surgical outcome in MEDs. Thank you very much.
Okay, your presentation is about your outcomes.
Yes.
So it is good, there is no doubt. I would have been a lot happier. There are studies which have, vertical muscle have been treated, and there are publications. If you had compared yours with that in the study, you put some references,
Yes,
but
yes.
I can't talk. It is hardly readable, but we
Yeah.
don't know the outcomes.
Yeah, so most of the previous surgeries...
No. In your presentation, you asked for 7 minutes, we gave 7. No, it should be there in any study, then only we will also understand whether you're doing something different that is outcome better or it's line with the other outcome. Definitely, if it is bad, you will not present. We understand that, but it should be somewhere in your presentation, always comparison. That is that's my opinion, sir.
One case you did a ptosis correction.
No, 4 patients needed
patients.
additional ptosis corrections because they had true Marcus Gunn jaw winking also. And
Sling procedure, which is...
for patients with type 1 MED with true ptosis, we just did a levator excision, but those with Marcus Gunn often needed a sling also.
Which is sling?
Yeah. Sling,
Which is
frontalis.
Frontalis.
Yeah. Patients were not agreeable to both eyes. We had to do it in... yeah, ideally, but moving possible. So if I can add, previous surgeries have done surgeries for the residual hypertrophy in the contralateral eye. But we have tried to do it in the same eye. That was the difference we noted in our study.
You are doing practically and really presenting that. Good.
Yes, thank you.